The final chapter assigned in Module 3 is Chapter 53, Alterations in the Integumentary System, or looking at the different various skin disorders. Before we get to the specific disorders, we should talk quick about age-related changes. And your book goes into a lot more detail, but just very, very briefly, skin changes a lot throughout our life. Babies have smooth, flexible, elastic skin that heals really quick when they're injured. At puberty, hormones start to kick in, sebum production picks up into overdrive, making skin appear oily and contributing to the development of acne. Sweat glands also kick it up a notch, which leads to body odor, which is basically the bacteria that's feeding the organic compounds in sweat and on the skin. Fortunately, as we reach adulthood, this slows down, but the skin can become drier and easier to injure. Other signs of aging include wrinkles, skin that sags due to loss of elasticity, hair becomes gray, and we develop baldness. How much sunlight you're exposed to throughout your life really impacts the effect of age-related skin changes. You can look through some of the other changes that occur in our integumentary system as we age. Box 53-1 talks about the changes in human skin. Looking at the skin can show us signs of dermatologic diseases. As you may have learned in health assessment, or you may be learning now, you want to note any lesions. And a lesion is any damage or abnormal change in the tissue of an organism, usually caused by disease or trauma. When you're describing a lesion, note if it's primary, if it retains its original appearance and it's not changed by time or external processes, like somebody who's itching because they've got pruritus, or if it's a secondary lesion, which has an appearance that has been modified over time and actually can look quite different from how it started. These changes that occur from primary to secondary, they give us clues as to what's going on. There are a whole bunch of characteristics. Figure 53-3 has some great images that show some of the different primary lesions and secondary lesions, and you are expected to know what these terms mean if you don't already. This might be a good time to take out flashcards to test your knowledge. In fact, let's try one. All right, so what is a fissure? And I'm not talking about somebody who has a rod and is trying to catch fish. You can put me on pause and think about it if you like. A fissure is a split in all of the epidermal layers of the skin. So you can see here in this lower lip, it's like a crack. Let's get into some different infectious processes that affect the integumentary system. We'll start with viral infections. Remember that a virus is an intracellular pathogen that relies on a live host cell for reproduction. Since viruses themselves, they don't have an organized cell structure, they're just some DNA or RNA that's surrounded by a protein coat. The virus that we see in skin lesion disorders tend to be more of the DNA type. They're able to get in to the keratinocytes and they begin to replicate, to reproduce, causing the cells either to quickly proliferate or die. And the virus that you see up here is a human papillomavirus, which is what we're going to talk about first. So we're going to talk about Verrucae, which you probably know of as warts. Verrucae are papillomas, and papillomas are these non-cancerous outward growing lumps that are actually overgrowths of the normal skin cells. Huma papillomavirus are the type that are exclusive to humans, so you can't get them from, say, picking up a toad. They grow on the skin and on mucous membranes as well. And depending on where they are in the body, they can look a little different, but know that there's also more than 80 types of HPV, so they can look different based on that fact too. Warts often resolve on their own as the body develops immunity to the virus, or they can multiply into hundreds of vesicles all over the body. Warts can be removed by laser, by burning them off with liquid nitrogen or acid, freezing them with cryotherapy, or salicylic acid. We can inject them with various agents. We can put topical blistering agents on them, and we can use immunomodulators. So lots of different approaches to removing warts. Another type of viral infection is herpes simplex virus, and there are two types that affect humans, type 1 and 2. I think type 1 is typically above the waist, and type 2 is pretty confined to the genital region. It should be noted that type 1 can spread to other parts of the body. Arm herpes is a thing if there's contact. So maybe you're an athlete, a dentist, a medical professional. A lot of people, though, who have had herpes will tell you they can sense when they're about to have a lesion or an outbreak because it feels like burning or tingling. The vesicle, which is, remember, a small blister of up to 5 millimeters in diameter filled with fluid that's located at various levels within the skin, it appears, and it's surrounded by erythema, by redness, which then progresses to pustules, which are elevated, well circumscribed lesions that contain a purulent exudate. It can lead to ulcers, which is that loss of skin through the epidermis. It's a type of secondary lesion. And also crusts, which are another type of secondary lesion. A collection of serous exudate and debris that collect on the surface of damaged or absent outer skin layers. And then about 10 to 14 days later, they can heal. After the initial outbreak, the virus stays in the body. It lies dormant in the trigeminal nerve and other ganglia, just waiting for the patient to become stressed. Maybe they get ill, maybe they have stress from school, or women on their menses, but whatever it is, it can return. Some people have as many as 10 of these often painful outbreaks every year. There is no cure, but there are meds that can be taken for pain, like lidocaine. Benadryl can help. Also, applying a cool compress can relieve some of that discomfort. And then there are some antivirals, Aclavir, for example, that can be given to shorten the duration of an outbreak, or sometimes taken every day prophylactically to prevent outbreaks. Another viral infection is herpes zoster, also known as shingles, which is acute, localized inflammatory disease of a dermatomal segment of the skin. So the image above shows a map of some of the dermatomes that might be affected by herpes. If you see the person with all of the different colored stripes, those are dermatomes. What happens here is that herpes zoster, it's the same virus that causes chickenpox, but it's in adults. And it's believed that the varicella virus lies dormant, waiting in the sensory dorsal ganglia, and it becomes reactivated traveling from the ganglia up to the dermatome of the skin. And what erupts are these painful vesicles, which you know from the slide before are these small blisters up to 5 millimeters in diameter filled with fluid located at various levels in the skin. And the interesting thing about shingles is that they form in bands following those dermatomes, generally on the thorax, the trunk, and or the face. Though in immunocompromised people, they might go off course a little bit. And these new vesicles, they appear every 3 to 5 days, and then they dry, they form crusts, and fall off. And this happens over a period of about 2 to 3 weeks. So in addition to pain, shingles cause paresthesia, which is this prickling or tingling feeling, and it can go on for a long time. Especially in the elderly, they can experience shingles for like a year. So what is really important that we do is to start treatment right away. We can do oral antivirals like Aclavir. We can put cool compresses on that can be used for pain, and even we can give systemic or IV corticosteroids for severe pain too. There is a complication that we want to watch for. It's called post-herpetic neuralgia, which is a complication involving permanent blindness if the eyes are involved, and pain that lasts for months or years. So the best thing that we can do actually in our 50-plus-year-olds is to educate them on the vaccine. We have a vaccine, came out in about 2006, I want to say, called Zostavax. And so we want to make sure that we encourage our patients to use that. Cool compresses, though, can help as well to help with pain. Fungi are free-living saprophytic plant-like organisms, and there are some strains that we naturally have on our human body. There are two types, yeast and mold. The picture that you're seeing here is a fluorescent antibody stain micrograph of oval budding Candida albicans. Candida albicans is a yeast that inhabits the mouth, throat, intestines, and urinary tract of humans. C. albicans, it recognizes and destroys harmful bacteria. The immune system and the friendly bacteria that we have usually control the growth of C. albicans. There are three different genera of fungi that superficially infect the human skin. The three fungi all lead to an infection called a tinea in any cutaneous area. And then the different infections are named for where they land. So remember, tinea is an infection of the cutaneous area of the skin. The signs and symptoms that we see depend on where the fungal infection is, but often they show up as erythematosus maculosus, or spots circumscribed to 1 centimeter that you can't feel. They're not palpable, so they don't rise up above or sink down below the surrounding skin surface. It can also form plaques, which are these lesions that are also well circumscribed. You can see kind of where they end. They're bigger though, and there is some slight elevation with some scaling and central clearing. We treat with topical ointments or creams that have antifungal properties. So if we're dealing with a fungus, we're going to use an antifungal. Generally about twice a day. They're prescribed for around 4 weeks, and that should clear it up. If not, we might have to hit it harder with systemic treatments. So taking orally versus just spreading the medication on the skin. Here are 3 different types of fungal infections, and remember that all fungi, they love to find areas that are really warm, that are moist, and that are short of air. So tinea pedis, we're looking at athlete's foot. You can see kind of between the toes. There is also, it's showing the cracked skin on top of the, Tinea corporeus is ringworm of the body area, and then Tinea capitis is on top of the head. So they're all tineas. The second part of the name just comes based on where on the body they are located. And another type of fungi is the yeast, Candida albicans, which exists on our body, as we said already, the vagina, GI tract, on our skin, and in our mouth. And overgrowth can happen when environmental conditions are changed, like if you're taking antibiotics or if you are immunocompromised because you're sick, you're taking steroids, whatever it is, which can lead to these superficial infections. So depending on where we see the different clinical manifestations, it can range from a white coating on the tongue with thrush to a red rash on the skin with scaling. So in the photo, you can see it's thrush, caused actually by the use of corticosteroids. Different treatments also depending on where in the body they are. Thrush, we have patients do like a rinse, a nystatin mouth rinse. They can also do troches, which are like medicated lozenges that they suck on. They dissolve in their mouth for over a period of 20 to 30 minutes. If it's on the skin, there's different topical creams that can be applied. And then there also are systemic meds patients can take orally. They ingest them like diflucan for a vaginal yeast infection. So a patient has tinea corporis. What area is affected and which organism causes this disorder? Put me on pause. Tell me what you think. All right, so hopefully you've made your choice. The answer here is C, trunk, and it's caused by a fungus. So tinea corporis is the trunk, caused by a superficial fungal infection. Tinea capitis is the scalp. Tinea fasciae is the face. Tinea cruris is the groin. And then bacteria, parasites, and viruses, they do not cause different forms of tinea. So let's talk about bacteria and what they do cause. Bacteria are also considered normal flora of the skin, and most are not pathogenic, but when they do invade the skin, superficial or systemic infections can develop. Bacterial infections are commonly classified as primary or secondary, and the diagnosis is generally based on culture. So we can swab the lesion and test it in a petri dish, see what grows, because treatment often includes antibiotics, and we want to make sure that the antibiotics that we choose are the correct type of antibiotics to treat whatever the bacterial pathogen is. If we just use broad spectrum antibiotics willy-nilly, or we use the wrong type, that is how we can develop these antibiotic resistant strains of bacteria. Treatment also, so in addition to the right antibiotic, are usually related to measures to promote comfort and also to prevent the bacteria from being spread to others. Impetigo is the most common cause of the infection of the skin, and it is bacterial. It is acute and it's contagious, pretty contagious. It has these vesicles, pustules, and then yellowish crusts that form. And actually, a lot of people carry the bacteria often, just in their nares and nostrils all the time, and it passes to skin in order to contribute to diseases. It's common for hospitalized patients to actually get impetigo from the infected hospital staff. So because hospitalized patients usually have lowered immune systems, they're more susceptible and they're able to contract the bacteria. Treatment includes topical ointments, but if there's a large area of skin that's affected by impetigo, then we would want to use a systemic medication. Syphilis is a type of sexually transmitted infection that is caused by the bacteria Treponema pallidum, or if not by sexual transmission from a pregnant woman to her baby. Without treatment, syphilis goes through 3 stages. The first is where a canker ulcer forms on the genitalia. Then in stage 2, the bacteria is able to spread through the blood, and what we see is a rash that develops on the body, which you can see on the palms of the hand on the slide here. It's pretty much like other rashes though, so really nothing that would scream, hey, you have syphilis. Both of these stages, stage 1 and 2, are contagious. However, they can be treated with penicillin. The rare tertiary stage happens about 10 to 30 years actually after the secondary stage. This one is permanent and it affects the cardiovascular and central nervous system, and this stage can be deadly. So best thing we can do is to treat primary and secondary syphilis with just penicillin, and educate our patients on prevention. So following safe sexual practices, wearing protection, things like that. The last of the infectious processes, we have leprosy or Hansen's disease, and your book doesn't really give a whole lot of time to it, so I wouldn't worry too much about this for your exam. It's a pretty rare disease. Only 95% or 95% of people are immune to it, so we don't see it around that often, and it's especially not very prevalent here in the United States. But it's related to a bacteria, Mycobacterium leprae, and it can affect your skin and your peripheral nerves. In order to contract it, so there used to be this fear that leprosy was super contagious, and they called them leopards, were kind of isolated. However, what we know now is that it really takes prolonged and close contact with somebody who is not being treated for months in order to contract the disease. So it's kind of a slow burn. To diagnose, we could do a little skin biopsy, test it, and then there are medications that leprosy is responsive to, but it's, a lot of drugs for a lot of medications over a long period of time, sometimes a year or two. And then if the damage has caused some permanent disfigurement, the patient might need some surgery to help to correct that. Lupus erythematosus, coming back again. This time we're talking about it specific to the skin. So, we've talked about it before. You can look at chart 53-3 on page 1070 in your book, comparing SLE to discoid lupus, and that's really what this is, a comparison of. Discoid lupus is pretty much strictly related to skin. I always remember discoid and dermatology helps me to remember that. But that's what we're seeing in the top picture, where you can kind of see the scaly red plaques that end up with scarring. And it happens on skin that's exposed to the sun. Remember that there's this link between lupus and UV exposure. Systemic lupus, I mean, this one you can also remember because systemic is talking about the whole body, but that's where we have all the other organs that are and tissues that are affected, as well as the skin, and where we see the butterfly rash that goes over the bridge of the nose and on the cheeks. And so you can see that in the bottom picture. Seborrheic dermatitis is this inflammatory condition. It's considered a papillosquamous skin disease, where the skin conditions are like red to purple raised scaly patches on the skin with some well-defined borders. So redness scaling around the areas of the body that typically have high oil gland concentration. So think like around the scalp, and the nasolabial fold, so around the nostrils, on your nose, the glabella, that's space between your eyebrows, on your eyebrows, and more. There's not a cure, but there are lots of different types of topical medications that can help, like using a selenium sulfide shampoo, or you can use 1% hydrocortisone, just a mild hydrocortisone cream on the face and on the ears. Psoriasis is a common chronic skin disease that happens when the immune system promotes inflammation and hyperproliferation in the skin. It leads to the formation of papules and plaques with an overlying silvery scale. So think silver psoriasis. We don't know why it's caused. Hey, we're back to that. But we do know that there is a genetic component that means that you can inherit it. Lesions can appear anywhere, but usually and most often they seem to be located on the knees, abdomen, scalp, lower back, elbows. And there is not a cure, but there are topical and systemic treatments that can be used, such as our corticosteroids. Those are kind of our best friends here as we're talking about these different skin disorders. Interesting, with psoriasis, you can use a UV light. With lupus, we want to avoid UV exposure, but psoriasis, it can actually help. There additionally are some topical tar preps. We can use methotrexate and other biologics, but again, when we get into those heavier medications, we're dealing with some of the heavier side effects, which I will not test you on, but you're going to need to start thinking about as you move through pharmacology and on through nursing and in our school and into nursing practice. Lichen planus is another inflammatory condition. It's also immune mediated. Lichen means tree moss, and planus refers to flat. So it's like a flat top skin rash that looks a bit like tree moss. It's pretty common, a common pruritic disease. Pruritic, remember, means itchy. And we don't always know what causes this. Sometimes it remains idiopathic, or we just never know. But other times it can be brought on by drugs and chemicals in someone who might be susceptible. Anyway, it leads to lesions on the wrists, ankles, trunks, and they are, as I said, it's pruritic. They are super itchy. And as people are scratching, they develop new lesions from all that itching. We treat it by stopping any meds that might have been contributing, and then we can give corticosteroids and use occlusive dressings. So we can do that topically. We can also give systemic corticosteroids if necessary, and then to relieve some of the itching, we can give antipyretic medications. Pityriasis rosea is a rash that affects young adults, generally in the spring and the fall, so it's seasonal. It seems to be viral, but we don't know that for sure. What we see is macules or papules surrounded by redness, and it spreads a lot, but it has central clearing. So you can see in the picture where it's spreading across the skin, but if you look in the middle, you don't really see that redness there. Initially, it starts as just one lesion, like on the trunk or the neck, but it can spread to the face, to the scalp, and it can be a little or a lot itchy. it usually goes away on its own in about 2 to 4 weeks. And so we treat, there's no cure, but we do treat to comfort, right? We provide comfort using topical steroids, antihistamines, Colloid baths, maybe systemic steroids if it's serious, and occasionally systemic antibiotics to help to shorten the course of I mean, 10 weeks is a long time to have a itchy rash. Acne is pretty common, you've probably heard of it. It affects 90% of the people out there, leading to some pretty gnarly lesions and sometimes permanent scarring and disfigurement. There's a range though, right? Some people just have mild acne and some have it where it gets pretty rough. There are a lot of precipitating factors. Hormones play a part, genetics, how much stress you're under. What happens, the pathogenesis, is that there's this lodging of sebaceous oil and a deposition of loose epithelial cells that block the follicular canal. Bacteria then can get in and it grows in combination with continued oil production, which leads to an inflamed lesion. Sadly, there is no cure, but we can treat by trying to clear the lesions and help to maintain clear complexion. And there's a billion-dollar market out there with all kinds of soaps and gels and creams and ointments and masks and stickers and gels that all help to dry out the skin and peel off that stratum corneum, that outer layer. There are prescription topicals as well, ranging from different acids to antibiotics. And then if acne is very severe, sometimes systemic antibiotics are indicated. Pemphigus is a group of related disorders with blisters. There seems to be an autoimmune component here where antibodies are made against keratinocytes, where they are separated from one another, and then these blisters are able to form. They grow and they erupt in the mucous membrane of the esophagus as well, which can be life-threatening if they lead to toxemia and death. So we really need to jump in and get treatments running with cortisone to prevent toxemia and infections and death. Atopic dermatitis is a complex genetic disease that seems to be linked to a maternal gene. So you get it from your mom. People with this genetic makeup have lower levels of natural moisturizing factor and are deficient in ceramides, which are these extracellular lipids. We can also see atopic dermatitis kind of comorbid with asthma, allergic rhinitis, and eczema. Characteristics depend on how old the person is when it begins, but regardless of age, pruritus itching is always present. So it's dry, itchy, allergic response. Treatment's typically done outpatient, so it helps to know what causes the disease. It shouldn't be a surprise that when we're treating, moisturizer is important, as well as controlling the itching. So all of the different things that we select and interventions that we do, they help to treat those things. Clients need to keep the skin free from irritants, so using really hot water can dry out your skin, so we teach them to use tepid water instead. We have them get rid of harsh perfume soaps, so they're really using very gentle products on their skin. And then applying creams right after bathing when their skin is even still a bit damp to lock in moisture. In more severe cases, patients might need topical steroids or systemic antibiotics. And then to treat the pruritus, we can use antihistamines to help with that. Contact dermatitis happens when the body is reacting to something that it's physically coming into contact with, it's touching. This is actually, if you remember back to the hypersensitivities, a type 4 delayed hypersensitivity reaction. You come into contact with the offending agent. Let's say, for example, you are wearing a bracelet that's made out of nickel, and within 48 hours, your wrist is itchy or red. Wrist dermatitis is contact dermatitis, but it has to do with plants. So when plants are involved, it's also a type 4 hypersensitivity coming into contact with the poison ivy, for example, and later you get the blisters, the rash that forms. Sometimes with poison ivy especially, you don't even know necessarily you've been exposed because the oil from the plant isn't really visible. For mild cases, calamine lotion works. For more severe, patients might need systemic steroids to be administered, but typically they expect to heal within 10 to 14 days. As a RN, medication administration will most likely be a pretty big part of your day-to-day practice, so this slide is important. Drug eruptions are adverse or undesirable reactions that happen after the administration of meds. And it's not like immediately after necessarily. Unfortunately, they're rare. So they're called cutaneous. They're skin reactions. They're rare in response to medications, but they can happen. So usually a cutaneous reaction happens within a week of starting the med. So you might not see it immediately. With penicillins, though, it can take longer. And then of all the meds that are out there, penicillin, ampicillin, cephalosporin, barbiturates are kind of the most common causes of these drug eruptions. And what we normally see, the most common reaction is a widespread rash that's itchy and goes away. If patient becomes itchy, we stop the med. A couple weeks later, they're good. Some patients might experience something called urticaria, which is talking about hives. A severe reaction is erythema multiforme, which includes Stevens-Johnson syndrome. This is a rare, even more rare, but serious problem. So most often, again, it's a severe reaction to a med you've taken. It starts typically with a fever. We're talking about Stevens-Johnson, and a rash in your face and chest. The skin, people complain that their skin feels painful, and eventually it causes your skin to blister and peel off. So that is what the picture is showing. I mean, it's serious, right? It not only affects your skin, but your mucous membranes as well, where blisters can form inside your body, making it hard to eat, to swallow, even to pee or urinate. Then the skin starts to shed. So we treat by stopping whatever the med is that is causing this. We give antihistamines, we give antipyretics to help with itching, usually topically, unless it's severe, and then we take the systemic route. So one other really important thing is that we want to make sure that if our patient has a drug eruption, that we note this in their chart. We tell them to let healthcare providers know, so that it doesn't happen again. Vasculitis is caused by an antigen-antibody reaction in the blood vessels of the skin. So it's not the blood vessels that bring the blood around your body, it's the ones in the skin. And it leads to severe necrotizing inflammation. There are underlying conditions like drug allergies, systemic conditions, infectious diseases that can contribute. Infectious diseases like hepatitis B, for example. The vasculitis can damage the skin, it can damage the brain, it can damage your visceral organs. When it does all that, it's called systemic vasculitis. We treat with high doses of systemic corticosteroids. A patient has an eruption of vesicles with erythematous bases localized to a dermatomal segment of skin caused by the same virus as chickenpox. Which disorder will the clinician observe documented on the chart? Go ahead and put me on pause. All right, if you answered B, herpes zoster, that is correct. Shingles is an acute localized inflammatory disease of a dermatomal segment of the skin. So caused by the same herpes virus that causes chickenpox, which is varicella zoster. Verrucae or warts are benign papillomas caused by DNA-causing papillomaviruses. The lichen planus is a relatively common chronic pruritic disease that involves inflammation and papular eruption of the skin and mucous membranes from drugs and chemicals. And scleroderma is characterized by massive collagen deposition with fibrosis that's accompanied by inflammatory reactions and vascular changes within the capillary network. Now we get to move on to parasites. Yay! Remember, a parasite is an organism that lives in or on an organism of another species, which is considered the host. Parasites benefit by taking nutrients or getting nutrients at the other's expense. So they're kind of little opportunists, right? What you're seeing on your slide is sleeping sickness parasites. Anyway, if your skin has not started crawling yet, it might start now. On this slide, we have two types of parasites, scabies and fleas. Scabies are what happens when you get infested with mites that burrow into the stratum corneum, which is the outer layer of skin, and they lay eggs. The eggs hatch 3 to 4 days later, and those baby larvae grow into adult mites over the next 2 months. A person gets scabies after close physical contact with somebody who's infected. What you see are these small erythematous papules that sometimes have an overlaying dry scale or crust to them. And occasionally, like you can see in the picture here on the left, you can see where the mite has burrowed in under the skin. It's called tunneling. Mites like to try to hide in the webs of the fingers, the umbilicus, your belly button, the groin, and they're treated using topical creams like permethrin. Fleas are another type of parasite whose bite causes reactions on the skin. They can appear as red macules, papules, wheals, or vesicles. They all lead to pruritus, though. They're really itchy. Fleas can multiply, turning into an infestation. As your book notes, there's a few different types of fleas, but interesting fact, the human type of fleas are very rare due to our modern sanitation. Fleas from cats and dogs, though, are still very present and can bite humans, too. There are a couple of pesticides that can be used to prevent infestations, like pyrethrins, and can also treat current infestations. You can also use calamine lotion, topical steroids to help with the itching. More parasites, lice or louse, singular, are parasites that can be found on the surface of the skin, hanging out near hair follicles. This is compared to burying themselves in your skin. Great. Crab lice are found in the pubic hair, near the genitals, head lice on the head, and body louse on the body. They crawl from one person or surface, like a comb or a hat, to the next person where they lay their eggs. They cause itching and can be seen with the naked eye. You don't need a magnifying glass or microscope to see the eggs. They are removed with medicated shampoos, and then people who have lice need to wash everything to get rid of them. Bedding, hats, etc. in hot water. Prevention includes things like not sharing items like hats and combs. Chiggers are little mites that hang out in the bushes, mostly common in the southern U.S. They bite the skin to get a little snack, and they leave behind a itchy papule that, when scratched, can cause secondary lesions. We often see bites around the sock line, belt line, or neckband areas where the chiggers get stuck and meet resistance. No cure, just treat the itching and use insect repellent for prevention. We've got some more bed bugs. So these little guys are nocturnal feeders. They feed on blood at night. And what happens when they bite is that their saliva causes this type 1 hypersensitivity reaction. Bedbugs spread very easily, and they're actually able to hide in bedding, floorboards, clothing, you name it. They hide everywhere. So they spread super easy. When they bite, it doesn't hurt. In fact, most people don't really realize that they are being snacked on as they sleep, but they'll wake up with these pruritic oval or oblong wheals with small hemorrhagic punctums. And as you can see in the picture here on the bottom, they tend to cluster on the face, neck, hands, or arms, but they can be anywhere on the body. Treatment usually calls for professional extermination because they are so tough to get rid of. As far as the itching goes, we can treat that with antipyretics. Mosquitoes, you all know about mosquitoes. This picture is especially disgusting. Saliva of the mosquito is what causes that skin reaction. And so when you're first bit, it can sting, right? You notice you slap the mosquito. And then what we see within the first 45 minutes is this raised wheal on an erythematous base, which is like a red base. And then in time, there's this delayed reaction where the bite becomes even more raised, redder, indurated, so it gets hard. And there is extensive pruritus and sometimes pain with mosquito bites. There's no cure, really. We just kind of have to wait it out. And so we can use antipyretics to help with the itching, calamine lotion, sometimes compresses can help. But the best thing you can do is prevention. So insect repellent with DEET, or just avoiding areas where mosquitoes like to gather. They lay their eggs in water, so a lot of times we see them more by lakes. Also, things like not having water sitting out in your yard can help to reduce mosquitoes. Ticks are also parasites that can cause some problems in people. So go back to chapter 52 for information about ticks and Lyme disease. We're going to talk here about ticks and Rocky Mountain spotted fever, which is caused by Rickettsia rickettsii, which is a bacteria that is carried by some ticks that are generally found around the Rocky Mountain region, although it seems like they're actually more widespread. What happens is the tick bites the host, and ticks feed slowly, so they bury their head into the host's skin and they start to drink blood. It's activated, in this case, 4 to 6 hours, the bacteria, after the tick has started to feed on the human, and then the bacteria gets carried into the bloodstream. At the site of the initial bite, we can see a papular macule form, and then about 4 to 8 days later, the patient will develop headache, fever, nausea, vomiting, muscle aches. They can develop rashes on their wrists and ankles, and it can also lead to generalized edema, conjunctivitis, petechial lesions, and then some neurological signs and symptoms like photophobia, which is a sensitivity to light, lethargy, confusion, and some cranial nerve deficits. So patients do need to be hospitalized and they need to receive antibiotics. The best thing that we can do here is prevention. So we teach people to check for and remove ticks right away. You might see people who tuck their pants into their socks to prevent ticks from kind of jumping on and finding a spot to feed. And when you are done being outside where you could be exposed, make sure you check your body for ticks. If you do find a tick on you, best to remove it right away. You can put some isopropyl alcohol on them to cause them to back out. They used to say to light a match and then put the hot match on the tick's back end, and that they would back right out. And they do, but it can also cause them to regurgitate back into your body. Scleroderma is also discussed in chapter 52, so please go back and look at that. It's important to understand not only how it can affect a person systemically, but also in talking about the skin. We know that sunlight is tough on the skin. What happens is that there's these short UV wavelengths that are responsible for sunburn. They cause the outer layer of the skin to thicken up. That's also what gives you a tan, and it helps to produce melanin. We can see, though, other more negative effects like losing elasticin. Other malignant disorders can develop too as a result of exposure to the sun. When we're talking about sunburn, there's varying degrees. On the more mild end, it can cause erythemas and redness. You might feel really hot, right? If it gets bad enough, it can blister, be really tender. In more severe cases, though, manifestations include chills, fever, nausea, and then just general discomfort. So the best thing that we can do, because once you have a sunburn, it's a little bit too late, so prevention. If we can avoid or limit the time that we're exposed to sun, or if we are going to be out, making sure that we're protecting our clothes or wearing protective clothing, hats, long sleeves, staying in the shade. And then there are tons of different types of sunscreens out there that can help to prevent those UV rays from getting into our skin. Ulcers are a huge problem in healthcare, and so something to start thinking about now and to be watching for. An ulceration, a pressure sore, can happen when there is Well, what it is it is a localized area of necrosis. The tissue, the cells die because of pressure between any bony prominence in your body and an external object. So if you're sitting down right now and you kind of bounce up and down in your seat a little bit, you can feel, right, that your sit bones are there and there's those bony prominences. And when we're able to get up and move around, we can shift and adjust and avoid pressure from building up, right? It starts to feel uncomfortable if you're sitting in the same spot for too long. In people, though, that are bed bound, then they're not as able to just move, right, when they need to. And so they are at higher risk. Other people who are at high risk are elderly patients. We know that some of the changes to the skin can exacerbate the condition and to the vessels in their body. Nutrition plays a part. Having sensory loss, if you can't feel that you're uncomfortable, then your body's not going to give you that message to move. Experiencing incontinence can make a difference as well. And patients who have dementia are at a really high risk. We do, for clinical manifestation, have this staging system that we use to kind of rate the severity of a pressure ulcer. And you have a table 53-4 or point 4 in your book that talks about these, and they range from stage 1, which is pretty minimal and superficial, to stage 4, where that pressure sore has gone in to the bone and it causes a ton of damage through the subcutaneous tissue. It's a full thickness skin loss. There's necrosis, muscle is damaged, tendons, joint capsules. So it can be pretty serious. So best thing that we can do is prevent these ulcers from forming. So keeping your patients dry, keeping infections away, making sure that we're turning and repositioning, that we're using, and then if our patient has the ulcer, that we are making sure that we're cleaning it and following wound care orders, giving them supplements as needed, and trying to keep them healthy. But really, prevention is the best thing that we can do. There are a couple different alterations of pigmentation, or the coloring of the skin. The one on the left is vitiligo, and this is actually what Michael Jackson has, or had, for those of you that were familiar, where a person loses pigment or coloring from a patch of skin. It can come on pretty suddenly. It happens a lot of times with darkly pigmented people, but it also happens in light skin individuals. And obviously, if you have a darker skin tone, then having these lighter patches are more obvious. However, even on light skin people in the summertime, that light patch where the vitiligo is, it does not tan. So the spots become more apparent. Usually it comes on before age 21, and there's a lot of different autoimmune suspicions that we think lead to the disease. Also, the affected areas over time can spread. So there are some different topicals, different immunomodulating agents that we can use, ultraviolet light. There is some different cosmetic procedures like Dermablend. Some people get tattooing done to help to hide and to mask the discoloration. And then the other type is albinism, which is albino. So either some or all of the melanin is gone in the skin, in the hair. And so these patients are really at risk for damage from ultraviolet radiation, and so talking to them about wearing sunscreen, sunglasses, and protecting themselves from those harmful rays is very important. There are some specific skin disorders that manifest differently or appear in greater or lesser frequencies in individuals who have dark skin. And so you can kind of look through what some of these things are. Box 53.3 has tips for assessing dark skin, and this is something that hopefully you'll be talking about more in health assessment, but these do go hand in hand, so important to know what kind of the expected differences are so that you know what the abnormalities look like. So let's talk about how systemic diseases manifest in the integumentary system. And we'll start by talking about the skin. And our skin really is kind of it's an obvious, we can see skin pretty easily, right? We cannot look inside and see internal organs just with our eyes. So the skin can be a good indicator of what is happening underneath. Remember that with systemic diseases, it's affecting kind of everything in the body. And so it all works together. With skin, we can look at color, and color changes can be a whole rainbow of colors they can appear as, meaning different things. So we've already talked about this quite a bit as we've gone through some of the different skin disorders, and we know that when skin is red, that it can mean that it's hot. It can mean that there is inflammation going on. It could be a rash. And we talked about a lot of those different things. The color orange can be present from carotene. It can happen with protein or calorie malnutrition that causes hypopigmentation in African American children, where their hair and skin can look almost orange. Sometimes skin can look yellow. This can happen when lipids are deposited in the skin, when there's metabolic deficits. But more often it's related to jaundice because of liver disease, where the bilirubin kind of gathers and accumulates and saturates the tissues. We can see that in kids as well, in babies. There are other things that can contribute, like smoking, things like that. We can see yellowish green color. We can see blue, and a lot of times we associate blue or cyanosis, like in the tips of the fingers or around the mouth or the nose, in people who have chronic cardiac or even acute respiratory problems where they're not getting that oxygenation. We talked about Raynaud's disease, where we can see blue or red. We can see indigo, which is in gangrene when we're looking at that. We can see violet with vascular insufficiency. We can see pallor or paleness. So all kinds of different colors that tell us different things. We can also look at sensation, and usually sensation in the skin includes like itching or pain. We can look at the skin's texture. Texture tells us a lot about hydration status. So we know dehydrated skin can look kind of dry and scaly, leathery even. Fluid excess, we can look and see if the skin is firm, and if we push on it, does it indent easily? Or we might feel indurations or areas of hardness underneath. Temperature, right? So skin can feel warm and dry, or warm and wet. Skin can feel hot. Skin can feel cool. So lots of different temperature changes that can tell us different things. We can look at hair as a manifestation of different systemic diseases. We can look at how quickly hair is growing. And because hair grows quickly relative to other cells, it is more susceptible to damage from disease and drugs and stress. It depends on hormones. We know, like, during pregnancy and childbirth, that can affect a woman's hair, and how she might have a whole bunch of it, and then after the baby is born, hair just, you look down the bathroom drain and it's disappearing. How much hair you have is another thing we can look at. Looking at hair distribution and just the regularity there. We can also look at hair color, and mostly that's just talking about hair that changes to gray as we age. And we can look at texture, looking at thickness. Can range from overgrowth to hair that's thinning or baldness. Lubrication of the hair can also be affected. So if we have sebaceous glands that are kicked up, it can lead to excessive oiliness. Dry, brittle hair can happen if somebody is using a lot of chemicals and applying that to the hair. We can look at systemic effects on the fingernails and the toenails. They can be affected by any serious systemic system, and also local diseases as well. So we can also, because nails grow so quickly, you can look at the distance between, say, pits or grooves in the fingernail, and it can give you an idea of the disease process and the time frame. We look at the nail's shape and look for even distribution. There can be furrows from infection. We can see clubbing, which might indicate hypoxemia over long term. Patients not getting enough oxygen. We can look at the color. So if the nails are blue, that's telling us, right, it's cyanotic. Where if they're really pale, it could tell us that our patient is anemic. And then we can look at the texture as well. Nails can thicken for all kinds of reasons, nutritional, infection, right? Sometimes there's debris that can build up if there's like a fungal infection under the nail, and it might need to be debrided. We have an advantage of treating skin because we can see it. We can see if our treatments are working. We're able to test pretty easily and figure out what the cause is. And once we know what the problem is and what we're trying to fix, then we can choose the appropriate delivery method to get that treatment in place. There are a lot of different topical treatments. Remember, topical treatments just get put directly on the lesion or directly on whatever is going on. And so we have wet dressings, which is liquid in a compress form. And it could be water. It can be water with other stuff added to it. They're pretty versatile. We usually apply them intermittently or continuously. So that's just kind of what it sounds like, right? Where we have it on, we take it off, have it on, take it off, or we leave it on all the time. There's also lotions. So lotions are these tiny little particles in a liquid like water or alcohol. And so we can use that to add moisture or exudative processes. So once the liquids develop, then it can cool and dry the skin. There are also emollient lotions that are oil and water. So whenever you hear emollient, think oil and water, a little more greasy. So they can also help with skin moisturization. There are gels, which are clear, colorless. They're pretty volatile and they penetrate better than creams. Creams we use the most often. They penetrate well as well, and they can moisturize at the same time. And ointments have a petroleum type base. They usually are good at going into the upper layers. And so anything that has like a dry scale or crust, we usually use ointments to help with. They are considered semi-occlusive. So if we have a lesion that's like oozing or they've got some kind of discharge, we don't want to put an ointment on that. And then there are aerosols or foams, which are these sprays of medication that are delivered like through a gas under pressure. So this can help on like hairy areas of the body where a cream or an ointment might kind of get stuck in all the hair. There are also intralesional injections where we can put the med directly into the lesion, either with a needle and a syringe that we draw up, or through something called a dermajet, which is able to inject. It's like a instrument that injects the tiny little particles into the skin with air pressure. Depending on the disease, the type of clinical lesions, and what a lot of times it's the practitioner's preference, that's kind of how we choose. So corticosteroids, I just want to mention really quick, are really commonly administered to reduce inflammation, and we can give these topically, intralesionally, or systemically, depending on what the patient's needs are. We do need to be careful with corticosteroid administration, especially systemically, because there are complications that are associated with it. We have to consider the age of our client too when we're talking about skin and problems of the skin. Some are specific to infants, some are specific to children, and some are seen in children and adults, but they might look a little bit different. So it's important to consider the age. Infancy, we talked earlier about how skin is usually pretty adaptable, and it is able to regenerate quickly. So anytime we have fast regeneration, we can see things like hyperpigmentation. Usually skin in infants too can be pretty sensitive to irritation, injury, to heat or extreme temperature. So we have to watch for that as well. So you can look at the different things that we might see in specific to infants. When we talk about childhood skin disorders, remember that infants are pretty dependent on their caregiver. They're not really coming into contact with a lot of other infants, at least direct contact. Kids, as they get older, typically have no concept of personal space. They spend a lot of time laying on the ground and kind of getting in each other's bubbles. So there's more a higher transmission of communicable diseases. One of those is rubella, which is also called 3-day measles or German measles, and it's caused by the rubella virus. And what we see is that there's this diffuse punctate. There's a macular rash that usually starts on the trunk of the body and then it spreads out into the arms and the legs. It can be accompanied by a mild fever, usually less than 100. They can develop adenopathy, swollen lymph nodes, sometimes cold-like symptoms as well, like a cough, maybe a little bit of congestion or a runny nose. And really, we treat based on symptoms. The good news is that rubella doesn't have any long-lasting problems, but one thing that can happen is if a pregnant woman develops rubella early on in the gestation period, it can have some pretty severe tetragenic effects on the unborn fetus. It can cause cataracts. It can cause microcephaly or a small head. It can lead to mental retardation, deafness. So we really want to keep, especially pregnant women, from getting rubella. A lot of states, it's part of the MMR, the measles, mumps, rubella immunization. You get one when you're infant and then another booster later on, usually like kindergarten, first grade. And those two are considered adequate. So we don't usually see rubella in immunized children. Measles is another preventable childhood skin disorder that is also in that MMR that I just mentioned. So this is like hard measles or 7-day measles. It's a communicable disease. It's viral, caused by morbillivirus. And what we see is this rash that is really blotchy and macular. Usually it starts on the face and then can spread out to the arms and legs. Here we have a higher temp, so greater than 100. Patients can develop these little Koplik spots, which are these small little red spots with bluish white specks in the center in their mouth. And they can also display this photosensitivity. So photosensitivity is sensitivity to light that can be mild, or it can be really severe. It can also be accompanied by cold-like symptoms, just not really feeling well. Sometimes what can happen is a macule can hemorrhage into skin tissue or onto another body surface. So that's called a hemorrhagic measles, and those are obviously more severe. Measles can lead to bigger complications, things like otitis media or middle ear infection. It can lead to pneumonia, encephalitis. So usually to diagnose, we can do an antibody titer to figure it out, and we can track that throughout the disease process and make sure that the patient has gotten over it. So preventable, often required by law, part of that MMR. If though a child does happen to get measles, there's not like a test. Really, usually it's based on symptoms. We keep them in a dark room. We can give them medications to bring fever down, bed rest, fluids, all those good things. And then we have chickenpox, which is another childhood disorder. And we talked about this in adults when we talked about shingles. So remember, chickenpox is varicella. It's pretty common. What we see are these skin lesions that happen in 3 stages: a maculovesicle and then a granular scab. And so you can take a look at what those look like. Sometimes kids experience other symptoms like a cough, runny nose, photosensitivity. So what can happen is that there can be complications like pneumonia, sepsis, encephalitis. Fortunately, they're rare. And chickenpox themselves can be mild to severe in how they present. So treatment is based on symptoms. We are going to give some antipyretics to help to lower fever. pruritus helps with like lukewarm, tepid baths. We can give diphenhydramine or Benadryl, antihistamines to help with that itching. There's topical antipyretics to help with the itching as well. Caladrol lotion is an example. But we have to be really careful because there can be overdose if you give diphenhydramine topically because it can lead to systemic absorption. And there is the varicella zoster is available as a vaccine. Scarlet fever, we talked about this too when we talked about the group A beta hemolytic streptococci, and patient usually gets it with strep throat, right? So a streptococcal sore throat, but it can happen on the skin as well. And scarlet fever, it shows up as a pink punctate skin rash on the neck, chest, in the armpits, the groin, the thighs. And if you were to palpate or feel that rash, it feels like really fine sandpaper. Patients also experience facial flushing. They can have high fever, and so kind of things that go along with that, nausea, vomiting. Their tongue can look raspberry or strawberry colored, so you can remember that, scarlet fever. It can lead to bigger complications as well, otitis media, peritonsillar abscess, rheumatic fever, which we discussed. And to treat, what we want to do is use penicillin. Just very, very briefly, adolescents, the most common skin disorder is acne vulgaris, and we talked about that already, so I'm not going to get into it again now. And then know that as people age and their skin is exposed to life and everything, that there are oftentimes some kind of skin disorder. In fact, 90% of the geriatric population has something. And so you can look through what some of those are. Skin as we age becomes more at risk for developing cancerous and precancerous lesions. So really important that we're doing that patients go to the dermatologist and get their annual skin checks done. All right, and that is the end of Module 3. Feel free to go back and rewind, listen to anything that wasn't very clear. You can use your textbook to supplement the extra resources built within the module. Thanks so much.